Okay, hello everybody. I'm Dr. Robert Wallace. I work with Safe Workplace. I'm the senior healthcare partner for Safe Workplace, and my work evolves around helping healthcare organizations succeed in the area of compliance, but also in the area of outcome, which fundamentally is our aim, is to get the best outcome for patients and also for staff and for organizations themselves. So today what we're going to have a chat about is the NHS 10-year plan, the Fit for the Future plan. So this is a very comprehensive plan, and I think that it is a healthcare plan that should be welcomed. It is a healthcare plan that is absolutely essential. Now, it is well recognised that the NHS is currently would be described as being in crisis. I think the Darcy report, I think people are or should be indebted to Darcy and the work that he and his team did, because they identified and vocalised what many people, both working in the NHS and receiving treatment in the NHS, had been thinking for some time. And it is unfortunate because I do believe that healthcare workers do the work that they do out of passion, out of great skill, and out of dedication to their patients. I think for a very long time in healthcare organisations in many countries, it has just been assumed that healthcare workers will simply continue to do their job because of this caring that they have for other people. But that's not reasonable. I think that they require a system that will support them and then ultimately support the patient. So, to be fair to Keir Starmer and his government, the Darcy report clearly stated that the NHS was crumbling, that the outcomes were deteriorating in the comparative to other countries, that there were very high risks to both the staff in the system, the patients in the system, and that it simply couldn't continue. So they are taking proactive measures. And this, while 10 years might seem like a long time, 10 years is not a long time in healthcare. I've been working in healthcare for 30 years, so I can tell you that 10 years goes by relatively quickly. So if you take no action, nothing will happen. If you plan like they have done and Fit for the Future, then I believe that there will be successes. But I do also believe that you can't present a plan without the expectation that people would, in a constructive way, criticize that plan. So what we're going to do today is we're going to go through the Fit for Future plan. It's a very comprehensive document, but we're going to just narrow it down to the key points and maybe just share our view on it with the hope of just contributing in some way to the understanding of what has been proposed. So I suppose the first thing here is the Fit for the Future. The plan is based on three key things. It is to move care to the community where possible, to move from analog to digital, and to move from sickness to prevention, a basically implementation of good population health strategy. Now, before we go through those points, I think that it's important to know where you're starting from. So just to give a quick run through on the Darcy report. So Darcy was given a free hand to be as honest and as critical as was necessary. And it identified skyrocketing waiting lists and extremely demoralised staff, which is shown on an annual basis through the NHS survey. So this was already known. And also it showed that comparatively to other countries, the NHS was not moving forward. So the care outcomes were not matching those of other populations. And I think this is fundamentally the basis of this report, okay, or of this proposal. Now, we will talk about finances. So the NHS has a massive budget, and in the last couple of days, there's been some, not harsh criticism, but some observation that there may not be adequate finance to implement the Fit for the Future plan. But it's not all about money. And I think that staff in the NHS will certainly tell you it's not all about money. Okay, so there are many positive changes that can be made without just talking about money. Okay. For me personally, I worked in primary care and I have done for a very long time. I have worked in an NHS hospital. I've worked in practice in the NHS. I was aware of the CQC then. I was aware of the demands that were on the team in the clinic that I worked in. And also in my own practice, I'm well aware of the demands outside of clinical care. Okay. So what might be of some help here is just a brief tangent. And I'm going to mention another 10-year Fit for the Future plan. And this is a plan called Sláintecare, which was implemented in Ireland in 2017. Now, at that time, we also had a significant crisis with staff morale. We had a significant crisis with the demands on the healthcare system. And with all healthcare systems, again, it would be argued that there wasn't enough money, but both Ireland and the UK do have significant health budgets. So, again, it can't just come back to money, which we will do later on in the discussion. So Sláintecare was implemented, ironically enough, to do the three same things that the Fit for the Future plan wanted to do. They wanted to move care to the communities, they wanted to digitise systems, and they wanted to improve prevention, so public health measures and messaging. So this plan has in fact been a success, to be fair. So waiting times have reduced in Ireland. A very significant part of this was the physical construction of primary care centres throughout Ireland. So there are now 180 primary care centres throughout Ireland, and these provide care for GPs, for physios, for diagnostics, for dental, for all different services. They're located in cities, they're located in medium-sized and small towns even. And this is where people go before they go to hospital. And this is a fundamental element of the Fit for the Future plan, because the cost of treating someone in secondary or tertiary healthcare is dramatically higher than the cost of treating somebody in primary care. And also the morbidity is much greater if you are treated in a primary care setting and your problem is resolved. Like with anything in life, if you solve it early, you prevent too much. So that part of the plan to move care to the community, to neighbourhood care centres, is likely to prove to be a very positive thing. Now, that will require work with the integrated care systems, the integrated care boards, but this has been included in the plan that they hope to set up a structure to allow for the best investment and the best integration. And this brings things like care homes, social care, treatment in the community, treatment care plans, wellbeing plans for patients, even employment coaching is proposed for these neighbourhood centres. So I think that will be a powerful part of what they would like to do in this plan. I think what we might discuss now is the next element of the plan. So what we're going to look at here is, I'm going to switch it around just a little bit. So they discuss it as hospital to the community, then digitisation, then sickness to prevention. But we might talk about sickness to prevention now, okay, because this ties in very much so with the neighbourhood care centres. This is about messaging to people to improve their behavioural habits and to improve lifestyle choices and things like this. Now, this is a contentious issue, okay, so Keir Starmer has been accused of trying to implement a nanny state. Now, politically and at its individual personal level, people could say, I don't want to be told what to do. But when the benefit of something is so great, and if you are still left with the choice whether you would do something or not, I don't believe that that is nanny state. So I think the Fit for the Future plan, if they work with public health and population health, I think there is quite a message and undertone in the plan about wanting to reduce inequalities of health. Okay, so this goes beyond treatment. This is about people's social well-being, about their mental well-being, about their economic well-being. And you might say, why do you use economics and all of these things come into at a personal level to a plan for the future for the NHS? And the reason being is if you reduce health inequalities across the population, the ultimate need for healthcare and for health services is greatly diminished. And also the well-being for your population is increased. And as I come back to it, people will still be left with the choice. If somebody still wants to choose to have a behavioral habit like smoking or drinking alcohol or not doing exercise, I think that is somebody's personal choice, which I don't really think can be argued with. But at the same time, the government has a responsibility to its entire population. The NHS has a responsibility to its population. And also, a population has responsibility to some degree to its healthcare system. So this isn't really a one-way street. There's a lot of talk about buy-in in this document, but I believe the buy-in has to be from politicians. The buy-in has to be from people in the healthcare systems. The buy-in has to be from patients and users of the system, but also people who currently don't use the system, because actions that are taken now will influence what services are available. It's a limited resource. So actions that we take now will influence the demands on the system in the future. So that is my view on the nanny state, the sickness to prevention. I don't think that it should be dismissed. I think that over a 10-year period, that is where you will see the impacts. Okay, so that is why these plans take 10 years, because you need to change the mindset and also the ability for people to, I wouldn't say change, but the ability for people to choose to change certain behavioral risks that they might have. And this would end up being quite a good thing for the NHS itself. So now I think we're going to move on. I was going to have a chat about digitisation of the NHS, but I think before we talk about that, I think it's essential to talk about the most fundamental part of the NHS, and that is the people working in the NHS. Okay, so Darcy didn't sugarcoat in any way when he discussed the morale and the well-being of people currently working in the NHS. And personally, yes, I haven't worked in the NHS for some time, but I spend a lot of time working with people who do currently work in the system. And I think it is extraordinary that people tolerate the work conditions and the duress and the burden that they currently do and still persist in looking after patients. And I don't think that should be underestimated in any way whatsoever. So when they talk about staff, they also talk about a workforce fit for the future. Now, it is proposed that another document, another plan specifically for workforce well-being and for healthcare staff well-being and retention will be released in a number of months' time. Now, that may have been a minor error to not include a much more detailed plan in this NHS 10-year plan, specifically focused on staff. Because in the opening of this plan, Keir Starmer has asked people to come with him. He has looked to motivate NHS teams and staff. But because these problems have persisted for so long, it becomes much more difficult to ask people to come with you if you haven't addressed their concerns. And these concerns did not require the Darcy report to be highlighted. They've been evident in the NHS survey, in every survey going back for many years. Okay, so I think if the implementation of this plan is to be successful, I believe what is proposed for healthcare staff will be absolutely fundamental, because they will drive the change. They will be what we would say the change managers. Okay. So it is unlikely to be a government department that is implementing change on the ground. Okay. So that is one part that I believe of the three key elements. I think that omission of a fourth element, focusing entirely on NHS staff, currently may be an error. But I am aware that there is going to be a proposal to manage specifically the most significant problem, I believe, which is in the NHS, which is staff morale and well-being and retention. Okay, so there are some references to it, but I think very much more needs to be done in that area. So we're going to come back to AI now. And the reason we're going to come back to this, I suppose, is one of our last topics on it, is because this is the area that I personally work in. Okay, so the area that I work in is in reporting, risk mitigation, and compliance obligation tracking. So we would have I would hope, an understanding of the CQC and of what compliance is required. And in my own area, I deal with the HSA and HICWA here in Ireland. Okay. So they have proposed that AI will now be used, not to be too flippant, but they've classed it almost as super AI will be used. Okay. Now, the problem with, I believe, in what they're proposing here is that the government are proposing to use AI to identify problems that are occurring in the system, and then this will prompt more intense inspection. It will prompt policy changes. It will prompt action and highlight what is going on. So these will be the areas of hospital-acquired infection, morbidity and mortality rates, etc. And while this is very powerful, again, this data has been available for some time. And while without AI, it was very slow to accumulate this data and absolutely extremely slow to analyze it and to act, AI won't change the situation as such. As in, what is happening here is that it will simply identify the problem after the problem has occurred. And my view on AI here is that if they're going to spend an awful lot of money on this and engage with companies and designers and build customized systems for the NHS, they may be much better off using AI at a much earlier stage in the process. So, for example, 40% of NHS A&Es in England are designated as requiring improvement by the CQC. This is also evident in hospitals. There are currently 3,500 inspections awaiting for facilities, NHS facilities that have a requiring improvement status. And I believe when it comes to AI, if it was implemented and integrated on a day-to-day basis at the level where NHS teams are working, that you simply would have mitigated the risk and removed the problems that they are now proposing to identify. So if you are compliant and if you follow the CQC rules and if your teams are enabled and engaged and included in this process, removing paperwork, having compliance obligation automated, what you can do is you can simply have hospitals where hospital-acquired infections, or they will occur at a much, much lower rate. Okay. And also where clinical audit may be included, your teams can be included to improve morbidity and mortality. So I do commend them for wanting to use AI and for engaging with this, but AI as a general thing without identifying the purpose for which you want to be used may not be, like everything. How you do it is what determines the efficiency. So personally, I believe that AI, if it was used at a much earlier level, would simply eliminate the problems. And I'm sure this will come up in discussion. They have mentioned things like interactive dashboards. They've had the NHS app, which again could have reporting built into that. So I just think that AI is an area that will just need some more consideration. Okay. When I come back to the whole system, let's say, the whole proposal, I think that, like any plan that's going to last over 10 years, I think it should be given every opportunity to succeed. I think that, again, fundamentally requires buy-in from staff and all team members. It requires buy-in from the public. It requires buy-in from people who use this system. And currently don't use the system. We have seen this succeed in Ireland, in Sláintecare, and this hopefully will continue to succeed in our model. I think that you need a system put in place to have continuous feedback and continuous correction of the plan. So again, these will be the systems that we have mentioned, and this will also be having integration between your primary, secondary and tertiary care facilities. It will require local leadership. It will require flexibility in the plan. And I think it will also require accountability. I think that you can't implement a plan of this scale if people aren't accountable, or let's say not so much accountable if people are not engaged, if people are not brought with you on the plan. So people have to be willing to change. People have to be willing to be open to critique. And I think then if you do this as let's say with some unity across what is a vast organization, I would very much hope that it would succeed, because ultimately everybody will be a service user ultimately. So at whatever stage in your life or whatever stage in your health status might be, it is going to be you or a family member or somebody that you know either working in the NHS or receiving treatment in the NHS. And it could be agreed that everybody would like positive outcomes. So I would hope it succeeds, and I would in fact commend them for listening to Darcy and for, in a relatively short period of time, coming up with a plan that it would appear that everybody could buy into, with all its good bits and maybe some of the bits that just aren't so clear yet. So that's my view on it, and I wish everybody working on the plan well. Thank you.